Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Addressing Current Knowledge and Practice Gaps in the Community, Optimizing the Use of Oral Selective Estrogen Receptor Degraders for Metastatic ER-Positive Breast Cancer. This is part one. We'll be doing another webinar later. We have a great faculty day. Dr. Komal Jhaveri from the Memorial Sloan Kettering Cancer Center in New York City, and Dr. Virginia Kaklamani from the UT Health San Antonio MD Anderson Cancer Center in San Antonio, and also co-director of the San Antonio Breast Cancer Symposium. Today, we're here as a sort of a kickoff to this important topic of ER-positive breast cancer, getting more and more complicated every day. As is the case in almost every program we do nowadays, we will be talking about the use of non-FDA approved agents and regimens, so check out the prescribing information for more. Here's where we're heading. I want to just kind of provide a little bit of an introduction to how we're going to approach this today, and then we'll talk a little bit about a survey we just did on general medical oncologists, and we'll talk about the questions these oncologists had, as well as a number of cases from our faculty today when we get to that part. So we did a survey with 50, everybody I think knows our primary target audience is general medical oncologists in the community, same docs not only taking care of breast cancer, but bladder cancer, CLL, myeloma, et cetera. So we did a survey of them, and they spent around 25 minutes or so responding to the survey. And mostly what they did was type a whole bunch of questions to ask you to. So more than 500 questions and comments that they came in. Of course, we had to put it into ChatGPT and AI. That didn't really help too much. So we tried the traditional AI, which is I sat down last weekend and read every single one of these comments and sort of shook it around in my head and say, okay, let me see if I can represent these people. And we'll show you some of the actual questions, but that's what we're going to mainly do today. I want to start out with this is one of many great review articles. Actually, Komal, you are a co-author on this paper in Nature Reviews, looking at hormone receptor positive metastatic breast cancer. Really the same content we're going to try to cover today as a lot of these review articles. I mean, tons of great scientific information and analysis. It's a lot of great graphics as well in terms of mechanism of action. You know, some in guidance in terms of practical clinical issues, but a lot of it was really translationally oriented and where we're heading in new directions. And what I'm going to do is try to synthesize that into put together that with what these docs put in the survey and come up with what I think, you know, is another way to look at this gigantic data set and make it clinically meaningful. I will say that this is a constantly changing field. We kind of fast froze it, you know, last week or two, but yesterday, another press release comes out. We'll talk about this later when we get into AKT and PIK3, but positive press release for another agent as currently not approved. It's going to be a challenge to pronounce it, but I'll just say gedatolisib. I know, Virginia, you can do a better job, but in any event, it's a pretty interesting agent, PIK3, and as well as mTOR inhibitor. We'll talk later. It's a positive trial. This is actually PIK3 wild type. You can explain to me later what this is all about, and as well as a number of issues in terms of new agents that are coming out. All right, so we're going to spend the first part of this conference, again, trying to query our faculty about practical issues and get their thoughts about what the oncologists here are saying. So we kind of thought about, first of all, let's just look at ER-positive metastatic breast cancer. And of course, you see at the top there, 3 SERDs, 1 approved, 2 others with very positive data, phase 3 data that people are talking a lot. Underneath that, you see PIK3, AKT, you're familiar with that. But also, we have to consider everything after this and where that's going to come in. And a lot of that, of course, relates to ADCs, TDXD and HER2 low, Dato and SASI, and all these patients. And another issue that's ER-positive disease, which is now HER2 positive, another sort of part of the ER-positive spectrum. And finally, new agents, and particularly this PROTAC inhibitor that Erica Hamilton presented at ASCO, and everybody in the survey was asking about it. Is there a need to do, you see we're doing all these conferences, but there's really a need to do this. There are a lot of patients who are in this category. In this survey, we took these 11 key trials that supported the 11 agents that I just showed to you, from ADC to SERDs, and said, how familiar are you with these trials, and would you like to learn more? And you can see that less than a third of people felt that they really understood what these trials showed in general, all the trials, and they want to learn more, and that's what we're going to try to do here today. Same thing when we asked them for we took the topics that we're going to cover today, same thing. Not too many felt really well informed. I don't, and I'm not even taking care of patients, so I can understand them. They want to know about it. And here's another thing I thought was very interesting, and I'll start out with you, Virginia. I feel like we talk about these things all the time, and then when you start to get out to these docs in practice, even though they see a lot of breast cancer, when new agents come out, it's surprising how long, it takes a while for them to get used to it. So I'll point out to you that even though we've been talking about the inavolisib triplet for PIK3 positive disease, more than half of these docs have not used it. I don't know whether that's because they're not seeing the patients or they're not aware of it, but seem like they're pretty well informed. Dato-DXd approved in January for ER positive disease. More than half haven't used it yet. And even though we saw the really amazing Patina trial and with Palbo being added in HER2 therapy, on average, they've only had one patient do it so far. So keep in mind that even though they do see a lot of breast cancer, particularly as it relates to new agents, there's a lot to go. Here's kind of another way to look at what we're going to talk about today. There are a bunch of new agents, particularly the SERDs, but also, as I mentioned, PROTAC, as well as PIK3 inhibitors, AKT inhibitors. Then you can think about the antibody drug conjugates. Often they're going to be second line after hormonal therapy. Which one comes first? And then the issue again of HER2 positive disease. So another way to look at, if you think about the content that was in that paper I talked about, you can also pick out these clinical points in terms of where we might make interventions. And Virginia, we can start out with first line treatment, and maybe you can just make a comment in terms of, sort of the first line setting. Obviously we have the issue potentially of adding in a SERD first line with CDK, theoretically, with the EMBER-3 study, imlunestrant and Obama. We talked about the inavolisib Palbo fulvestrant triplet for PIK3 positive disease. And now, of course, as of ASCO, we have the issue of monitoring ESR1 and treating at that point with, quote, molecular progression with camizestrant. So we'll get into the specific questions that come up with each, but any comments, Virginia, about this first line scenario, how it compares to where we were a few years ago and where you think it might be in the next couple of years?
So I think at this point, it's pretty similar to what it was a few years ago, minus the NAVO data that I think is extremely compelling. So the first line is going to be a CDK4/6 inhibitor with either an aromatase inhibitor or fulvestrant, depending on prior therapy. But if a patient's tumor has a PIK3CA mutation, it's also endocrine resistant per the NAVO 120 criteria. I think considering an NAVO is extremely important. Good overall survival data. Komal's the first author, and she's very, very familiar with that data. As far as the SERENA-6 trial and monitoring ESR1, I don't think we're there yet. I think we need to see more data in the future, but it's a very interesting approach as well.
And we're going to talk about all of these, and just again to provide sort of an overview of the topography of what we're talking about here, Komal, because it may seem obvious, but again, for docs who are like dealing with different patients every day, it helps to just take a deep breath. You don't see a chart like this, incidentally, in some of these papers, too, that go through all the scientific data. So I think also about second-line therapy. Of course, the first question is, are you going to use endocrine therapy to start with? And we're going to get into that in terms of how to make that decision, particularly versus ADC that seems to keep moving up. Particularly related to time on CDK, which seems to be a good clinical predictor. Then you have the issue of, okay, you have an ESR1 mutation, you want to use a SERD. Right now you have one agent available, but there are two other agents that are out there. We'll talk about that later in terms of how they compare, as well as other newer agents, for example, PROTAC and this other Gita beginning drug. And then finally, the issue of repeating CDK in the second line in the post-monarch approach with Obama, and then even taking it one step further, as was in the EMBER-3 trial that Komal presented last, it seems like years ago, but I guess it was last December, of imlunestrant and Obama. So again, Komal, before we get into each one of these things individually, any sort of global view of second-line therapy, that you want to comment on.
Yeah, I think the very first point, Neil, would be, is this patient still appropriate for endocrine-based therapy? And I think our goal usually with the ER positive tumor is try and give them 2 to 3 lines, if possible, sometimes more, and delay time to chemotherapy as much as possible, with the exception if you're not responding to your first line therapy the way you are expected to, if it's not durable enough, and we call that primary endocrine resistance, and we define that as, say, less than 6 months on first line therapy, when we know CDK4/6 is supposed to give you a median PFS of 25 or 28 months. We worry about that tumor. We want to think about it differently. And that's when we think about these ADC based treatments. So that's the first goal. The second, as I said, we want to try and utilize as many treatments as possible. And usually in the second line, our treatment selection is biomarker based. For ESR1 mutant tumors, as you said, we already have one SERD approved. We are other data. We have for PI3K mutant tumors, agents targeting the PI3K AKT pathway. We saw the press release and the data you're referring to with gedatolisib, the PI3K and mTOR inhibitor in PI3K wild type, which is 60% of our tumors. So some good excitement or advance there in terms of thinking about how we can move the needle in the right direction with more prolonged and durable benefit. But that's where we are right now. We're trying to delay chemotherapy, and that goal has stayed right now.
All right, so before we get into specific questions and your cases, we'll just do a little bit of a Neil GPT summary of what I heard from these docs. Here are my top 10 issues. We're just going to fire through them. And we could probably spend 15 minutes on each, but I'll just, briefly get into what I think are some of the key issues. And one, actually, at the top, before we get into the questions there, is Virginia, like, how do we look at these patients in terms of the mutational profile? And we know there right now, to me, like 2 key determinants, ESR1, PIK3, AKT, P10. It kind of reminds me a little bit of ER/HER2, bimodal, 2-factor thing. You can have both positive, you can have neither positive or one positive. It's essentially 4 mutational subsets to think about. Is that an appropriate model for today in terms of how to look at this? And we have a lot of questions about the type of assay and when to do it. Any comment on how liquid biopsy fits into putting a patient in one of these 4 categories, Virginia?
So I think, yes, we look at it that way because we have targeted agents. So we have elacestrant currently approved for patients that have tumors with ESR1 mutations. We have alpelisib, capivasertib, and inavo for patients that have tumors with PIK3CA mutations. And then around 15 or so % of patients, there will be co-mutations of ESR1 and PIK3CA. And there we have all of those agents to kind of pick between. Now, how do we test these tumors for PIK3CA? We want to test in a regular biopsy, and it could be archival biopsy as well. This is a mutation that it's a truncal mutation. It'll be present in the initial tumor and then in the metastatic site as well. We can also test with a liquid biopsy, but for ESR1 mutation, we definitely want to look for a liquid biopsy. This is a subclonal mutation, develops over time as a tumor is exposed to endocrine therapy and becomes more resistant to endocrine therapy.
All right, well, let's get into my top 10 list. We're going to start out with what seems like a pretty obvious question, but it's never that simple in oncology, which is, how do these agents work? How do SERDs work? I had this vision. Here's actually a graphic from the Serena-6 presentation where I thought it was interesting. They say complete antagonism there. I'm not sure, maybe you can talk a little bit. A lot of people are curious about, Komal, how these work. But at a different level, Komal, we did a program recently when we mentioned Dr. Jesselson is going to be on a webinar with us in a couple months, but we did a program with her last year, and she really surprised me because I thought it was very simple. It's just SERDs, get rid of the ER receptor. And she was like, nah, maybe it's not quite that simple. And Komal, you have a great way of explaining pathways with your hands. So without slides, can you just explain in your own words how these drugs work?
I love your memory about my hands and my explanation with my hands, Neil. So thank you for bringing that up. Yeah, no, I think it is, it's you would think it's a simple way of thinking about this and the mechanism of these drugs, but it's not that straightforward, which is true with many things, I guess, in life. But particularly so when we think about SERD, as you say, the definition itself, the acronym itself means it's a serum estrogen receptor degrader. So a simple way would be something is degrading the estrogen receptor, and that's what we would think fulvestrant would do. But turns out it's not a complete degrader of the estrogen receptor. In fact, it's an incomplete degrader of the estrogen receptor. It causes ER antagonism, it reduces the ER transcription, but the degradation is not necessarily complete. And on the other hand, we have these novel newer endocrine agents made be an oral SERD or mechanistically slightly distinct a PROTAC, which is a proteolysis targeting chimera. Turns out they degrade these receptors better. So the PROTAC has a unique mechanism of action. It binds to the estrogen receptor and the E3 ligase together, causing ubiquitination and proteasomal degradation. And an oral SERD, unlike fulvestrant, which is the intramuscular SERD that lacks the oral bioavailability, can be given at doses higher and can do better degradation of the estrogen receptor than fulvestrant can because it's limited by its dose. And it was an interesting, you'll appreciate this fact, Neil. There was an interesting study looking at fluoroestradiol PET. So it's a special kind of a PET scan that looks at ER expression. And if you have a low FES PET uptake seen, then it is the degradation that it's reflecting eventually. If you have a very high, it's also reflecting how much degradation you could achieve. And when they did that with fulvestrant to look at how much we could see, turns out there was enough still left behind, suggesting that it's an incomplete degrader of the estrogen receptor. So I agree with Renathan that while we think it's a degrader, it's not doing a great job at completely degrading the estrogen receptor, which is why we need better optimized oral endocrine agents.
And also that some of these agents, particularly elacestrant, is, quote, a SERD and a SERM, but we'll get into that later. I think it's enough, I'm pretty much still on the upstream, downstream understanding of pathways, but I guess the main thing is how it works clinically. And here's another question that came out a lot in these questions, Virginia, which is second-line endocrine treatment versus chemotherapy, or more likely an ADC nowadays. And or do we have, the paper that I mentioned talks a lot about future molecular predictors of, what to do. But I'm curious right now how you make the decision. When I look at it, the thing that really struck me the most of all the things that I personally read, and I heard a lot of people refer to this, was time on CDK, which I guess is sort of a reflection. And this was a study done with elacestrant, where they found that people who'd been on CDK more than a year or were the ones who were really benefiting. Is that one of the things you consider when you try to decide between, let's say, an ADC and second-line endocrine therapy, short relapse on CDK, Virginia?
It really is, and that's because we're just not good to biologically and molecularly understand endocrine resistance in real time. So we have several criteria. What is the ER percentage and PR percentage, Ki-67, and how much visceral disease there is. But in the Emerald trial, we actually looked at visceral disease, and it didn't really seem to make a difference as to whether patients had liver metastases or not and what the response to elacestrant was. That's why we looked at CDK4/6 duration. And the reason we did is because when you look at first-line CDK trials, the median progression-free survival is around 2 years. And so if I have a patient in my office who's been on a CDK within 6 months to a year and has disease progression, in my mind, I'm thinking this tumor is already endocrine resistant, and I want to be thinking about giving a cytotoxic agent. And so that's why we did that analysis, and it panned out that the patients that still had endocrine sensitive disease per CDK duration still received a pretty good, robust benefit from elacestrant.
So we'll drill down on this more when we get to the individual questions from the oncologists as well as your cases. But another sort of broad stroke, Komal, that I heard everybody asking about is, like, we know there are at least 3 SERDs out there that are certainly in front of everybody's mind because of one approved and 2 others that have really positive phase 3 trial. What's optimal in terms of that? We have elacestrant that's been out there, as we mentioned, approved, PFS advantage in mutant patients. But you have similar data for camizestrant, similar indirect, hazard rates. And the same thing for imlunestrant, part of the AMBER-3 trial. And actually, this is before the AMBER-3, the interesting waterfall plot, I think, in terms of, if on the left there is imlunestrant monotherapy, where you do see some tumor shrinkage even by itself with the abema. But then again, with the AMBER-3, we saw similar indirectly, at least the arm imlunestrant monotherapy. And I remember at San Antonio, people were saying, like, do we need another SERD? It looks like the same, but maybe you'll have patients who won't tolerate one and can go to the other. And again, here's the AMBER-3 data. Same thing in the mutant patients that you see with the other two. So Komal, right now, how would you compare them in terms of efficacy, but also tolerability? One of the questions one of the oncologists asked, is there one that's better tolerated that they might be more combinable, the way sort of Palbo was with CDK, or are they all kind of similar, well tolerated?
Yeah, no, it's such a great question. I think, we as a community have definitely had the situation happen to us before. We have 3 aromatase inhibitors that we use, and, somebody might prefer anastrozole and somebody might prefer letrozole, but they are equivalent in many ways. We have 3 antibody drug conjugates, certainly 2 TROP2 ADCs. We have 3 CDK4/6 inhibitors. And while the efficacy is similar, there are some nuances in their toxicity profiles, which makes, sometimes choices dependent on that. Certainly, ribociclib has become popular because of the overall survival advantage consistently seen. So when it comes to oral SERDs, my general impression for monotherapy data is that they are almost similar-ish. They seem to be working, all having a common signal as monotherapy post-CDK4/6 inhibitor in an ESR1 mutant tumor. Not to say it doesn't work in wild-type tumors. It's just that in wild-type tumors, due to the other complex mechanisms that are driving tumor growth, we've not been able to show superiority with statistical significance when compared to standard endocrine therapy. So they're at least as good as standard endocrine therapy for wild-type, but better in mutants. But I think when it comes to efficacy, we've also appreciated that if you look at the curves up top, whether you go on the standard of care or on the monotherapy SERD, there is a drop off initially, and 40% will have this progression regardless. And then 60% progress within 6 months, which is why we think about combinations. And this is where data like EMBER-3 that had combined data set for imlunestrant and abemaciclib gave us some more hope with durability of 9 months post-CDK. And so when we think about which one do we choose, certainly the first kid on the block has the advantage of being the first kid on the block that's available. People have used it. People have gotten used to, ordering it with specialty pharmacies, and the tolerability profile are equivalent. I think my experience is overall, all of them are very well tolerated with low-grade toxicities. Some have slightly more nausea, maybe some increase in the cholesterol, which is elacestrant. Some might have slight more diarrhea, which is imlunestrant. And then camizestrant has some low-grade bradycardia, low-grade photopsia. So overall, less grade 3, well tolerated, efficacious as monotherapy. Combination might make us think about one. We have prospective data on one. We'll see more prospective data with giredestrant come out soon. So we might have more and more data, and I think combination is going to be the future. And then we'll start utilizing, depending on the data sets that might be available and approvals that might be there for combinations in clinic.
When you mentioned photopsia, I just flashed on the fact that our last webinar was on ophthalmic issues in oncology. And we spent the whole time talking about ADCs and keratitis. And in the middle of it, somebody in the chat room goes, well, what about photopsia? I guess it was on everybody's mind since the ASCO meeting. And so we talked about that, which is obviously very different. So another issue that came up, Virginia, it's amazing. ASCO, we just had it last month, and everybody already heard about the big PROTAC presentation. And of course, a lot of questions about, if this agent, also there's I think a SERM, lasofoxifene or something that also is looking promising. You have new mechanisms, new encouraging data. We're going to get stuck again with sort of indirect comparison. We're going to focus mainly on the things that we've been talking about that we haven't seen in the last couple of years. But any thoughts about where PROTACs are going to fit in, particularly in ESR1 mutant patients? Can you do a PROTAC and a SERD in the same patient, Virginia? Any thoughts?
We don't know that, but we do know that the VEPDEG data looks very similar to the data that we've seen both with imlunestrant monotherapy and elacestrant monotherapy. A benefit in the patients that have tumors with ESR1 mutations, the benefit seems to be very similar. And again, as Komal mentioned, that the toxicity from VEPDEG is relatively mild. So this is a win for our patients, more options for them. I think probably we were hoping for a little more because these PROTACs are supposed to inhibit the ER more than SERDs. We always thought that we may see activity in all patients, not just patients with ESR1 mutated tumors, maybe even more activity in ESR1 mutated tumors. We didn't see that, but I think just get another option for our patients. So I'm excited about that.
So another issue, of course, again, we talked about Serena-6. Interesting that it was called, and the discussant there called it molecular progression and anatomic progression. And bottom line is the development. It kind of reminds me a little bit of CML. I don't know if we're kind of moving in that direction, looking, molecularly before you see clinical changes. But obviously the idea of looking at people who develop ESR1 mutations on first-line therapy, mainly with a CDK inhibitor. We saw the presentation by Dr. Turner and simultaneous data in the New England Journal. I think everybody's familiar with what they saw there, which was an improved PFS. I mean, hazard rate of 0.44, going from 9 to 16 months. Classic question in oncology, Komal, is a PFS enough? I mean, it comes up in lymphoma and all over the place. Is PFS an adequate enough endpoint? It kind of, I think Virginia sort of alluded to the fact that it seemed like people at ASCO and since are kind of not exactly ready to move, but maybe in the next data set, more PFS2 data. The discussant talked about how PFS2 is very predictive of survival, so maybe we're close to this. But any thoughts about this strategy? And I'm sure the people are going to end up getting tested and coming to you for second opinions. What are you going to say?
Yeah, no, I think it's, first of all, I would like to say that it's a very novel strategy to think about how can we intervene early and should we intervene early such that we can actually make a difference in the outcomes, right? Are we doing interventions to make an improvement in outcome is what the idea here is. And this is not a novel idea. We tried to do that with, say, tumor markers in the blood with CA15-3 or CEA back in the day. We wanted to try and do that with CTCs, and we did that with circulating tumor cells as well. But we just couldn't enumerate a lot of circulating tumor cells to make that difference, and it did not necessarily impact survival. And so now we're trying to do it with current day novel technologies like ctDNA, which we're utilizing for patients anyway for next generation sequencing data for treatment selection. And so this is what this trial did as well, similar to PADA-1, which was truly the unprecedented way of trying to figure this question out. Should we serially monitor? Should we intervene for molecular progression so that we can make an improvement in outcomes? Now, we achieved the question, if we do early interventions, will we change the PFS? The question was answered. Yes, we can. The question that is still not answered, which is what Virginia is referring to, is did that intervention change the long-term outcome? And what is the long-term outcome we're referring to? That's overall survival. And we don't have that data. Right. And so the way to think about this data then becomes a little tricky. While it's novel, while it's the future, which is what we want to do, and we really want to continue doing such efforts, I think what we've learned is we need to tease out a little bit more from trials like this, from data sets like this, and make newer versions to figure out how can we make that difference, or are we just using up good therapies up front and not making a difference in survival? The median time to developing ESR1 mutations in Serena-6 was 22 months. So it takes you 22 months, and then after 22 months, the control arm got a PFS of 9 months. So if you add that up, that's about 31 months. And when we think about first-line AI CDK studies, the median PFS is around 28 months. If we think about the investigational arm, Neil, we're saying 22 months to develop the ESR1, and we get 16 months with the interventional arm, so we get to 38 months. But if we gave a SERD at the back end upon radiological progression and achieved 8 months, because we can, from the subgroup analyses of Emerald that Virginia was talking about, get maybe a durable monotherapy effect, we can get up to 39 months for the control arm as well. So that's why we're trying to still understand the implications of these data. While attractive, This is what we want to understand better. On the other hand, there could be some test anxiety, but also some patients could appreciate the fact that you're monitoring it so closely and intervening and would want to understand that better. And maybe the quality of life data supports that as well. So I think it's an important strategy. We need to tease it out better.
So we could spend a whole hour just on Serena-6, but again,
Yes.
this is sort of a tasting menu just to get started here. I'll just mention in terms of, we talked about the triplet with PIK3 up front. One thing that's interesting is we are seeing, Virginia, you mentioned these people need to be endocrine resistant. We've seen people say they want to use it in de novo. I'm not sure. I don't think the indication would allow you to do that. And also another question would be how closely you look at hemoglobin A1C before you begin this triplet, because I think in the trial was pretty strict. I'm not really sure whether people are even looking at it. And not to mention the fact that half of our audience hasn't even done it once. But I also want to get to, actually, this is just brought up in the chat room. Here's the Innovo data. So Muhammad in the chat room, Komal says, at this point, are you giving SERD and CDK inhibitors outside a clinical trial in combination, and which ones? So I think that's a pretty good lead into, as we were mentioning, the EMBER-3 trial. And before that, of course, we saw the post-Monarch study, looking at the issue, first of all, CDK after CDK, which was, part of the strategy in EMBER-3. And we saw that in this study, when we did abemaciclib as the second CDK inhibitor, we saw a pretty good efficacy signal there. And then when you presented the EMBER-3 study, now not only repeating the abema in some cases, some of these people had never had a CDK, but most of them had, but now adding in imlunestrant. So maybe you could just sort of walk us through, Komal, the design of the study, the main findings. When this was first presented, there was a lot of confusion in my mind to try to interpret. I remember talking to you in San Antonio. I think it's a lot better now, but let's just go back over it because it is a really amazing study.
Yeah, no, I think it is. It's almost like answering two questions in one, which makes it a little tricky. So it's good and bad at the same time, right? So let's try and break this down to keep it good. So these are patients who have recurred on or within 12 months of completion of their adjuvant aromatase inhibitor with or without CDK, or on their first line metastatic therapy, again, with an aromatase inhibitor with or without a CDK and no other therapy for advanced disease. And then 874 patients were randomized to imlunestrant alone, oral daily dosing, standard of care endocrine therapy, which could have been fulvestrant or exemestane. And within 6 months of the study initiating, a third arm was added to look at imlunestrant plus abemaciclib. And primary endpoints were to look at PFS for the two monotherapy arms in all patients and ESR1 mutant tumors. And if either of the two were positive, then look at the doublet arm in arm C, compared it to imlunestrant. And what we showed was that the PFS benefit was seen in ESR1 mutant only. For monotherapy, it was 5.5 months, which is why we then looked at imlunestrant plus abema, which showed 9.4 months for the doublet compared to 5.5 months with imlunestrant alone, which was statistically significant. And unlike the mono benefit, which was restricted to ESR1 mutants only, the benefit for the doublet was seen regardless of ESR1 mutation, median PFS 11 months for the doublet in mutants, 9 months in the wild type.
And then, of course, Dr. Burstein actually did the discussion in San Antonio and is in inimitable way put up this slide and said, I know I'm not supposed to show indirect comparison, but I have to do this because over there on the right is the EMBER-3 combination arm with the PFS over 9 months. We already talked about, he reviewed the different toxicities, which as we just talked about before. So Virginia, I'm just kind of curious, Muhammad in the chat room wants to know, would you like to use that strategy? Right now, obviously, imlunestrant is not approved. I mean, I guess theoretically you could use elacestrant, but just sort of theoretically, is this sort of, from your point of view, ready for prime time, Virginia?
And we do have at least safety and some early toxicity data, efficacy data with elacestrant plus a CDK4/6 inhibitor. So we could potentially do that. I haven't. I think we need FDA approval before we do that. And remember that all of these strategies did not look at sequencing. And this is always an issue that we will have. Are we getting the same benefit if we sequence than if we combine? And we're not going to know the answer, at least not anytime soon. But I think a very interesting strategy that we may very well be using if imlunestrant is approved by the FDA to be combined with abemaciclib.
Kind of curious, Kamal, if you could, are there situations where you would use imlunestrant and CDK upfront, abema upfront? There were patients like that in the EMBER-3 study.
So I think that's a great question. And 30% of these patients in EMBER-3 were treated in the first line. As a reminder, EMBER-3 was recurrence on or within 12 months of endocrine therapy. And so if there is a patient like that, and say for whatever reason, I already also know the ESR1 mutation status. I recently had a patient like that in clinic where I knew the ESR1 mutation status, which is 5 to 7% at baseline before first line therapy. If I had that and that drug was available, I would be very, very comfortable using that, even more so, even though the wild type data looks good. So I don't think it's going to be for all. For sure. I think it's predominantly a second line regimen in my mind. But for an individual patient like that, I would be very open to using that as was studied in EMBER-3.
So one of the most common questions was, what about the patient with both a SERD, with the ESR1 and AKT or a PIK3 mutation? Which comes first? Can you use one after the other? And I mean, we've done a lot of surveys on this, and we'll ask Virginia to comment on it, but I know it depends a lot on the situation. If the patient's stable, they don't have visceral mets, and it's not urgent, it may be one thing. You look at the time on CDK, et cetera. But I wasn't aware of this data, which I thought was kind of interesting, looking at the impact of SERDs in patients who are PIK3 mutated and the reverse. So actually, it turns out that it was looked at for elacestrant in the EMERALD trial, and it looked like it worked just as well whether they're PIK3 or not. The key thing was ESR1. Actually, same thing, I believe this is EMBER-3, looking at imlunestrant and abemaciclib in PIK3 mutated disease. Again, similar data regardless of that. And from what I understand, which I didn't even realize, the AKT trials with inavolisib, capi, and alpelisib didn't actually look in the trials. I meant to ask you this before to make sure I was right. I hope I am. So Virginia, is that correct that we know that it works if they're with the SERD, but we don't really have data with the AKT PIK3?
We do have data with alpelisib, and it seems that when you look at, again, cross-trial comparisons, we hate doing them, but we do them all the time. Whether you give alpelisib plus endocrine therapy or single-agent elacestrant, the median PFS you get from these co-mutated tumors is around 5.5 months. Now, again, the issue with elacestrant is you have to pick the tumors that are still endocrine sensitive per CDK4/6 duration of more than 12 months. So I think you're justified to do either. This is going to be dependent on patient's tumor. If I see the tumor progressing a little bit faster, and I'm thinking of potentially giving chemotherapy, if I decide to give endocrine therapy, I'll likely give the doublet with an AKT/PI3 kinase inhibitor. If the tumor is not progressing as quickly, doesn't have a lot of disease that I'm very worried about, I'll likely give elacestrant monotherapy because it's so much better tolerated.
So final question on my top 10 list, back to you, Kamal. We saw this really incredible data with the Patina trial looking at CDK, Palbo, and HER2-positive disease. And even when the press release came out that DB09 was going to be presented, people are already talking about, what are we going to do? Because Destiny, they used indefinite TDXD. So what I'm hearing is people say, yeah, they're probably going to switch to, at least in a lot of patients, TDXD first line, but maybe they're not going to give it indefinitely the way the trial is. They're going to stop, use some kind of maintenance, and if they do, maybe use Palbo. We know right now when you use Cleopatra, at least when we ask investigators, they're using Palbo, period. But whether they're going to do it with TDXD, any predictions, or what do you think you're going to do, Kamal, if you can?
Yeah, no, I think, again, it's a very important question. I think the one thing that we're also eagerly awaiting, Neil, is the monotherapy data for TDXD from the DB09 study. Because right now, I think what was read out was just the TDXT plus pertuzumab arm, and the way the trial was set up and the events were set up, they were going to come in early for TDXTP, which is why we see the results for that, but not yet the way the alpha was assigned and the event rate was assigned statistically. And so hopefully the TDXT arm will also result, because if we use up TDXTP first, what do we do after is also another question. So many, many questions still remaining. The trial, however, did allow to continue TDXT with or without P until maximal response or toxicity. So if somebody had toxicity, the trial did allow you to stop. It turned out that many people did not use the endocrine therapy as one would have expected for ER-positive tumors, but certainly that trial did allow that. So I think I could still think about that. There are some patients who tolerated really, really well, and I would continue for those patients. If patients do develop toxicity, I could stop. I'm not sure I'm going to give this to every ER-positive, HER2-positive patient. We have the patina data, we have the THP data. If they have just a few metastatic sites, they're otherwise doing really well, I'll be okay utilizing the patina data with 44 months median PFS. For our ER-negative tumors where we don't have a patina-like approach, it does seem like DB09 does offer that unmet need gap that I would like to fill. So I think we have to just see once we have approval. I have to say, insurance approvals for Palbo is also not super straightforward. I've not been able to just get it very easily. So while we're talking all of this, it's possible we might not get access to them no matter how we want to do it.
Yeah, that's a great point. And here again is the patina data and really the surprisingly positive data that was seen there with a real huge increase there in PFS outcomes. I'll just point out, you can check out the slide set. We put in a bunch of ongoing trials looking at SERDs, particularly as you could have mentioned in oncology. We're always moving things up. I love this preoperative window of opportunity studies. I remember hearing those for trastuzumab alone a long time ago, and this looked at immunoestrogen, really cool, before surgery in operable people, showing pretty interesting impact on Ki-67. Now there's a trial looking at switching after a couple years from hormonal therapy into immunoestrogen, when there are a bunch of other studies, one with CAMI, and you can imagine all these agents are being looked at in earlier stage disease. And here's kind of a sampling of some of the questions you'll see a little bit later from the oncologists. A lot of them are asking about SERDs in earlier in stage disease, the adjuvant setting, where, I don't know, Virginia, do you see ESR1 development people just on like an adjuvant AI, for example?
So we know that in that first line metastatic setting, the rate is pretty low, around 5%, as Komal said previously. And obviously in the adjuvant setting, it's going to be a little lower. There are clinical trials going on now looking exactly at that, looking at ctDNA and looking at the development. The concern is that we're not going to have enough patients to be able to randomize them once there is a development in the adjuvant setting without any disease recurrence, to then randomize them to an oral SERD versus continuing the endocrine therapy. But that's where Elegant and EMBER-4 come to play, where we're almost assuming that some of these patients with high-risk disease will have developed after 2 to 5 years some ESR1 mutations, and then you randomize them to either continuing the endocrine therapy or switching to an oral SERD.
So just note a couple of other points made here by these docs. One of the issue of adherence to SERDs, I think an interesting point. Also, everybody has these traumatic experience with alpelisib they refer to. They never want to use another AKT inhibitor again, but I think the new ones are a lot better. Also, interesting question, would you add Palbo to somebody who's already on maintenance HPAI, post Cleopatra? But Komal, you wanted to add something to what Virginia just said?
Yeah, I just wanted to say that, I completely agree with Virginia about how these trials will hopefully capture. So I do appreciate the switch strategies in some ways because of that. But as I was saying, it's not that these oral SERDs and these novel agents are inferior to standard endocrine therapy when they don't have ESR1 mutations. It's just that in the metastatic setting, post-CDK, the heterogeneity and the biology makes it very complex to prove statistical significance. It is an endocrine agent. And if it's an optimized endocrine agent, it should work in early stage wild type tumors really well. And I think adherence is such a big issue in the early stage. only 50% of our patients complete 5 years of adjuvant endocrine therapy. And if we can move that needle to better, then certainly we can hope to have better outcomes and better results. And the other advantage with these oral SERDs is that in their metastatic setting, none of them reached MTD. They all had drugs, the dose chosen based on PK, safety, and PD profile. So certain of these drugs can be dose reduced, which is not the case with AI or tamoxifen. We give them one dose. If they can't tolerate it, they come off, right? But with oral SERDs, we can even give them these dose reductions. So I'm hoping that the adherence will make a difference and that it wouldn't matter whether they have a mutation or not. But I agree with Virginia's point about the switch strategy where we can capture some of the mutations.
It's interesting, though, when you think about these trials using it in the adjuvant setting, and you have a very good therapy, so you have to be very confident to randomize a patient, but it sounds like there's a lot of reason. Maybe it's going to even be better than our current approaches. All right, let's get into more, practical day-to-day stuff, particularly your cases. So you have these are real cases from the practices of the faculty. This is a patient of Virginia's, a 42-year-old premenopausal woman. The bottom line with this case is she ended up on elacestrant for 12 months. She had some grade 1 nausea, had to get some ondansetron. And then, Komal, you had a 57-year-old postmenopausal woman, also with ESR1 mutation, also been on elacestrant now, I guess, since last fall, doing well, intermittent nausea and fatigue. And I just wanted to ask you both in terms of, a little bit more the granularity of what happens to these people as they're taking a SERD. So Virginia, when you think about the course of your patient, how disruptive was the nausea? What was her quality of life like? Was she continuing her normal lifestyle, work, et cetera?
She was. And when you look at the data, that patients will receive an anti-nausea medication for, a couple times a week, but it won't be a daily use. And if you look at Emerald and the use of antiemetics, the patients receiving elacestrant used less antiemetics than the patients on an aromatase inhibitor. And whenever we talk about aromatase inhibitors, we never think, oh yeah, they're nausea-causing medication. So it really is low-grade GI toxicity.
Yeah, I'm thinking maybe at 5 years on a SERD, if that's where we end up someday, or in combination or not, might be easier than 5 years on an AI or, for that matter, tamoxifen, and particularly if you have to have ovarian suppression, because that's another issue. So, Sarah, we've covered a lot of these questions, but just to go pick out a few that we haven't. Just to kind of put things in perspective here. First, this is kind of interesting. Do they have advantage over intramuscular fulvestrant? And, Komal, you just went through this argument. I remember when fulvestrant came out, it was like, can you give them 5 shots or something? Because it didn't have any side effects. But, it works better than fulvestrant for that reason. But I wanted to also get into a couple of your cases with patients who were on trials that we've talked about. So first, Komal, you have this 53-year-old woman, a postmenopausal lady. Can you talk a little bit about what happened to her? And she, I believe, ended up on EMBER-3.
Yes, that's right. So she progressed on first-line AI CDK4/6 and then had mutations in ESR1 and had liver and bone metastases. And so at the time, we had the EMBER-3 trial, and it just seemed like I wanted to do more than just single-agent therapy, given the extent of her disease. And we enrolled her. Unfortunately, she actually got randomized to the arm C, the doublet arm. So this is what I think Virginia was talking about as well when we were talking about dual mutations and how do we think about single drug versus 2 drugs. And I think, the disease burden and what kind of therapies they've had and, what the benefit they've had in prior therapies sometimes drive our decisions about combination therapy or not. But more importantly, we're learning that combinations does give us more durable benefit. EMBER-3 did give us 9.4 months, in post-CDK setting 9.1 months, which is longer than what we've seen. So that encourages us, and the gedatolisib data in wild-type tumors that you were referring to from Victoria 1, again, for the first time, we're seeing in wild-type tumors 9 months with triplet strategies as well. So obviously, when you add more drugs, you're seeing more benefit. So if the tolerability profile is good, you would prefer that. And in EMBER-3, abema, imlunestrant tolerability was very good with discontinuations of only 6%. So we've been able to learn to manage the diarrhea of abema, and I think turned out to be a good choice for the patient.
Yeah, it looks like she just had grade 1 diarrhea, obviously, again, from the abema. I'm curious, too, Kamal. I noticed that her first CDK inhibitor was Palbo. And of course, this patient went on a trial, but now we're post the trial. Do you look at which the first CDK inhibitor is? Because if you go abema after palbo, it's one thing. But what about if they got abema first line? Does that change how you look at the idea of the EMBER-3 strategy, Kamal?
Yeah, no. So those patients were far too few in EMBER-3 to be able to address that in a very definitive way. And at least what we've learned from PACE and Parmira, that if we continued the same CDK, Palbo after Palbo, we did not see the benefit. If we switched both the endocrine and CDK, like in Maintain phase 2 trial and in Post-Monarch phase 3 and now EMBER-3, we have been able to see the benefit. So I'm not sure that I would be super enthusiastic about that approach for abema, post-abema. Having said that, definitively for abema, post-abema, we don't have a prospective trial. EMBER-3 only had like 9% of the patients, or nine patients, I want to say, very few, 10 patients.
You also see in this case, again, a lot of questions about post-endocrine therapy, particularly what comes after capecitabine. Here is obviously this patient with HER2 low. She got TDXD. It looks like she's responding. Of course, you have the issue of suppose they're HER2 zero. If they're HER2 ultra low, you could spend a lot of time talking about that. But I want to hear about your patient also, your 56-year-old woman who also as well ended up on EMBER-3. What happened with her, Virginia?
Yeah, so she's a patient that had initially a high-risk disease, especially with a 21 gene recurrence score of 27. So she received chemotherapy, then was put on an anastrozole, and then unfortunately had development of metastatic disease. Started because she was already on the AI when she developed metastatic disease. She was started on fulvestrant and palbociclib. Had an 18-month period of response, which is okay, but a little bit less than the median seen in all of those first-line trials. But understandable because it wasn't really a first line. And then the liquid biopsy showed an ESR1 mutation, and thankfully she was able to enroll on EMBER-3 and received, again, the combination, like Komal's patient, of imlunestrant and abemaciclib. The combination will give you a little bit of diarrhea. And importantly with the diarrhea, we keep thinking of grade 1 and grade 2 toxicity as mild, maybe mild to moderate. Diarrhea is a little different. Grade 2 diarrhea is 4 to 6 bowel movements above baseline a day. So to me, this is really life-altering and something that we need to address. And if the antidiarrheals work, great, but I'm not afraid, especially when it comes to abemaciclib, I'm not afraid to dose reduce at all.
And also, thinking back to Dr. Burstein's slide, this patient was on therapy 15 months, kind of lines up with this 9-month jump that you saw, I guess, in the median with this study. So questions. All right, so again, one of the most common questions ever since SERD came up, Kamal, the patient with both AKT or PIK3, PTEN. I don't know how this new, again, GITA drug with that, in PIK3 wild type, where it's going to fit in. That's like totally over my head at this point. We'll have to go to chapter 2 for that one. But let's just stick with a more common question right now, Kamal, of how you think through if they're doubly mutated. Obviously, if it's in first-line setting, you have the option of the triplet if they're endocrine resistant, and maybe considering also their hemoglobin A1C status. But how do you maybe further talk a little bit about how do you make that decision between, I guess, what is often capi, visertib, and elacestrant or a SERD, Kamal?
Yeah, so I think the first thing I'd like to say is that when we think about how often do you see these double mutants, right? So PIK3CA mutations, if you think about, are 40% of ER-positive breast cancer. And that's a truncal alteration. And if you think about ESR1 that's acquired in about 40 to 50% of the patients, you're saying 40 to 50% of the 40% will have both. So this narrows it down to about 15% in clinic. So that's the prevalence for these double mutants. And we really don't have data yet right now for optimal sequencing. And I agree with Virginia's strategy. We look at what prior therapies they had, what was the duration on CDK, what is the disease burden, what kind of comorbidities that they have. If they have frank diabetes, I'm not sure I'm very excited to use the agents targeting the PI3K pathway, for example, and would go with elacestrant until I optimize their diabetes management. But hopefully we'll see data sets. We're going to see Evera, which is giredestrant plus everolimus. So we'll have an oral SERD and everolimus that, will have activity regardless of the mutation. We will hopefully see newer combinations with newer PI3K drugs or AKT drugs with novel endocrine agents in the future, and we won't have to keep guessing what to do for sequencing and just give them that therapy. But until then, we will have to rely on these, factors for individual patients and come up with an individual plan.
So, Virginia, you'll appreciate this next question. I just literally copied it from the survey. Why is imlunestrant still not available when the New England Journal paper is out in December 2024 showing impressive activity from the team? I think it was the triplet study that you guys went from press release to presenting it in 3 days or something. So you all have your act together in terms of presenting it. Virginia, any comments about when or if we're going to be able to use imlunestrant?
Regulatory process. It takes a little while, and in some ways it's a good thing because they cross their T's and dot their I's and make sure that all of the data is especially with these global trials where the data is coming from Asia, they need to make sure that this data is solid. So it takes a little bit of time. The good news is we have alternatives right now. We have other SERDs available, and this is coming up.
So here's another question. I always love hearing you all talk about Komal male breast cancer. So this entire huge, gigantic ER-positive scenario, how does it apply to men?
Yeah, it applies a similar way. It's just that, obviously male breast cancer are less prevalent, and the number of cases of breast cancer patients who are men we see are lower, but they were eligible for clinical trials. For instance, even the INAVO 120 study enrolled men. In fact, I enrolled a man at our site who still remains on the INAVO 120 trial. He's been on that regimen for years now. And we allowed that even in EMBER-3. And so it's not that they are going to be treated any differently. It's just that there are far too few of these patients with male breast cancers. And that's why the enrollment to these clinical trials doesn't necessarily reflect as a big number of patients. But there are a few patients who are male who enroll to these trials and should be treated the same way. The only difference is they do require Lupron. Sorry, I just wanted to add the Lupron is what the quality of life changes because these trials do require them to get Lupron, and that could be a little tricky for these patients.
Yeah, no, to me, the paradigm has always been, men are like premenopausal women who get Lupron, at least the way you all treat them. So, Virginia, a lot of questions that come up related to the efficacy of SERDs. It's one thing to see a PFS and hazard rate, et cetera. And it's another thing to really see it play out in practice, particularly as you saw, the average doc still has only used elacestrant, I think, 5 times. So, they don't have the depth of experience that you all do. So you see questions like this: would you consider a SERD in somebody with visceral disease or visceral crisis, high disease burden? Another person wants to know, can you share a case where oral SERD significantly altered the course of a patient's treatment? Any comments? Any granularity? Do you ever see responses? Do you usually see stable disease, Virginia?
Yeah, absolutely. So you don't want to give an oral SERD single agent in visceral crisis. I think that in that case, you're going to give your cytotoxic agent. But visceral metastases, absolutely. Data from Emerald suggested that these patients don't do any worse as long as they have still endocrine sensitive disease by duration of prior CDK4/6 inhibitor of more than 12 months. I actually just saw a patient in clinic a few hours ago who's been on elacestrant now for 20 months. And she's had disease response initially for the first 2 scans and now has had stable disease since then, doing great quality of life. So definitely something that we need to consider. One of the reasons why some of your clinicians have not seen patients on elacestrant is because the testing is still not as much as we should be testing for. We have much less ctDNA testing. If we don't find, we're not going to, we don't look, we're not going to find. If we don't find an ESR1 mutation, we're not going to know that the patients are eligible for elacestrant.
I have to say that's kind of a surprising thing to hear, but we seem to we talk about it all the time. You would assume it's a blood test, but again, it's a challenge to be in general medical oncology practice nowadays, and hopefully we can be of assistance, and I hope this was a past hour was of assistance, and we'll deal with other questions as we move forward. Thanks so much to you, Komal, and to you, Virginia. Audience, thank you very much and have a great night. Thanks so
Thank
much,
you.
Komal. Thanks,
Thank you.
Virginia.
Thank you.